Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County, with another of our Facebook Lives. Today is January the 12th, 2021, and we'll do our Facebook Live tonight. The way we do the Facebook Live is we'll talk about some of the worldwide statistics and some of the local statistics, and then we'll go through the questions. So there are a bunch of questions that are already in the page, and we'll get to them, and we'll get to them as best we can. We'll go as long as we need to. Anyway, so in the world, still a very active pandemic. I'm sad to say 92 million cases, and I think, sadly, today we'll hit 2 million deaths. So a really, really active pandemic in the world, very active in the U.S., still very active in places like the U.K. Portugal's really had a lot of troubles. The Czech Republic, Sweden, Lithuania have had troubles with the disease. In the rest of the world, there's still a fair amount of disease in South America. And remember now, South America, this is the height of their summertime, so it's a little worrisome to still see a lot of disease there and a lot of disease in South Africa. We do worry about South Africa because South Africa is frequently a harbinger of what's going to happen in the past. It's one of the more developed countries that far in the southern hemisphere, and so we do worry about that. In the U.S., 23 million cases, 389,000 deaths. I saw today that using the Greenwich Mean Time day, we had 4,259 deaths today in a single day. 4,259 deaths. You know, there's no way to compare different things, but when we compare horrible days in our history, like 9/11, Pearl Harbor, Gettysburg, Antietam, these terrible, terrible days, we're talking about death rates in the same range. And so it's so worrisome that the deaths are going up. So again, if you remember, around the holidays, it's hard to know what was going up, whether the cases going up or going down, or they're just not getting reported. But it's very clear that cases are not going down. In Oregon, we're at 127,000 cases, 1,667 deaths. They reported 54 deaths today. Now, the deaths in Oregon, the way they do these is that there's a death, and it could be a COVID death. It gets reviewed before it gets counted as a COVID death. And the 54 they released today were deaths that did get counted as COVID deaths. Douglas County, we're still doing reasonably well. We're at 1,596 cases, 42 deaths. We had 9 in the hospital. So we were down to 5 or less last week, and now we're up to 9. And again, hospitalizations are really worrisome. But we're still low. We're still the second lowest big county in the country. And we are doing far, 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 far better than those doppelganger counties in Idaho, South Dakota, and Georgia. We this week squeaked under the 200 per 100,000 over 2-week thing. And so we still remain in the high but not extreme range. And so restaurants and bars and gyms can be partially open now, and schools can be partially open, and they've done that. Much of the question this week is going to be about vaccines. We'll get to that. A lot of other information is going to be there, so let's get to the questions. So Lynn says, can you tell me about Meprazole and COVID? So if you remember, early on, the Chinese recognized that rich people did less well with COVID than poor people. Rich people tended to take Meprazole. Poor people tended to take Pepcid. And so the question was Pepcid a protective effect, or was Meprazole a negative effect? And I think there's some data that there's probably both, so that probably Pepcid might be slightly protective and Meprazole might be slightly problematic. And so if you take Meprazole, you should talk to your doctor, and you might want to switch over to an H2 blocker like Pepcid. But again, please talk to your doctor. So someone says, talk about the shutdown. People are all worked up about shutting down business and destroying the economy. Well, so there's data behind this. So every day I get notes saying, well, why are grocery stores open and bars closed? And it is because bars and grocery stores are very, very, very different. Grocery stores tend to be very large places, super high ceilings, 20-foot ceilings with incredible ventilation. You go in a grocery store, you can almost never smell a bad smell because they've got such great ventilation there. When you're in the grocery store, at least the one I shop in, almost everybody wears masks. And the interactions I have people with in the grocery store are fleeting. I'll pass somebody in an aisle. I may be waiting at the butcher counter, but I'm 6 feet away from the person ahead of me. And then when in the checkout line, I'm 6 feet away with a mask on. I then check out, which takes about 2.5 minutes, and then I'm gone. So while I'm at the grocery store, none of those we would consider close contact, which is generally within 6 feet for more than 15 minutes, higher risk if you're not wearing masks. Now consider that when I go to a restaurant, and I go to restaurants, and I love going to restaurants and bars, but if I would go to a bar with a buddy, we'd sit down, we would not have masks on because we'd be eating or drinking, we would tend to be arm's length apart, and we would be there for, if we were watching a game, 2 or 3 hours. If we were there just to talk, we might be there for a lot longer. And again, the risk in that bar is that now this person is direct contact. Well, going out with one person, not a big deal, but going out with a big group is even more problematic. And that's why we have done this. Now, again, we would love to have no restrictions, but if we had no restrictions, we would likely have the number of cases that places that few restrictions have had. So, for example, South Dakota has proudly had very few restrictions. They have 4 times as many cases and 5 times as many deaths. I mean, yes, that's a choice you could make, to have more cases and more deaths, or to have some restrictions and fewer cases and fewer deaths. And we in Oregon had made that distinction. I mean, I don't want to get down on anybody anyway, but we've made this decision. I think this is a very reasonable decision because the economic impacts on those places that have had a lot of people in the hospital have also been severe. And people will disagree, and I think we can disagree, but the only thing I'm asking when people disagree is let's be kind about the disagreement. Where you set that line, whether restaurants and bars at our case level should be open 25% or 50% or totally closed or totally open, that's a logical discussion we could have. But when it starts to get ugly, it makes it so hard to talk about the data behind it. So when are the start and end times for the 2-week county times? So the weeks are counted in what's called the morbidity and mortality weekly review week. So every week they review how many diseases are around, and that week starts on Sunday at midnight and goes to Saturday at 11:59. And 1 week is the movement week and 1 week is the warning week. This week was the movement week, and we just squeaked under 200. So, we're good for 2 weeks. In a week, we're going to do a warning week. I will tell you that I follow this number every day. So that's the number of cases per 100,000 over the last 2 weeks. And we were at 199 by my calculation on that day. We're now a little over 200. So we really have to work on bringing cases down. So Bruce says, why are such a high percentage of Oregon's vaccines not administered? What's the holdup? The paper says we've only used 25% of the vaccine statewide. Well, there's a couple of issues that go on here. I will tell you, in Douglas County, our county health department received 200 doses 2 weeks ago, totally gone. 200 doses last week, all gone. And then we got 500 doses today. Those 500 doses we got this afternoon. We didn't know when we were getting them. That we arrived this afternoon are still in the refrigerator, but I think they'll be gone by the end of the week or early next. So there's those vaccines. However, we in Oregon gave 12,000 vaccines, a fair number, or even more than that now, to the Federal Pharmacy Partnership, and we don't have visibility onto whether they were given. So that's a worrisome thing. And then some large health systems were given big amounts of doses early on. For example, Kaiser got lots of doses. They gave them to all their people, and that was all of their healthcare workers, and had a bunch left in the freezer. I think there's an incredible effort this week to redistribute those, so we expect to get a lot more in Douglas County, and that will be absolutely great. So is Douglas County receiving all the doses requested? No, we'd love to have a lot more doses, and we are clearly campaigning for a release. So I was been on the call with all kinds of different people in the state today, trying to get more and more vaccines, because I think in Douglas County, with our strategy, we could give more and more vaccines out, and that would be a great thing. So Douglas County's approach is a twofold approach. One is we will have some big events once we get more vaccine, but in the meantime, with the smaller dose of vaccine we've gotten, we have prepared a bunch of different vaccine sites in the county to be ready to give it. So in the future, when we hope to be giving 1,000 doses every day, what we would hope is that of those 1,000 doses, rather than being one big spot, wait in line for hours and hours, that we would have 30 different places in the county that would each give about 30 doses a day. And so they would be some of the regular clinics you know about. Some of the clinics may give more. They're doctor's offices, so we've already worked with a bunch of doctor's offices for them to do health people in phase 1A in their area. We think EMS is going to be a big deliverer of vaccine. And then we've had some non-traditional people who can give vaccines but generally don't step up to do it. So a surgery center in town has suggested they may want to do it. A bunch of dentist office will do it. So the hope will be that when we finally get enough vaccine, we'll say, here are one of 30 places to go for a vaccine, and we'll figure out how to get that. So rather than these big long lines, which worry me, because these big long lines are another way to spread the disease, we will be able to say it would be one of these 30 places, go get your vaccine. So I'm really, really pleased at how things are going with the vaccine rollout in Douglas County. I'm just a little disappointed that we don't have more vaccine. So someone says they're living in Canyonville, they're immunocompromised, 69 years old, 2 caregivers who come in 5 days a week. Why can't I get a vaccine along with my caregivers? So the whole world of vaccines has been planning for these vaccines since the beginning of November. Early on in December, we got from the CDC and the ACIP about how we would go ahead and do the phasing. Oregon did some more things, and we have really got all that phasing down, and we were ready to do it this morning. The White House announced that we're going to get rid of those prioritizations and basically combine groups 1A, 1B, and 1C. Well, there were about 12,000 people in 1A, about 20 or 30,000 people in 1B, depending on how we defined it, and another 20 or 30,000 in 1C, and now they're all the same priority. That makes that is an opportunity for chaos, because there's no way in the world we're going to get 60,000 doses of vaccine anywhere in the next few months. And so this really is going to lead to a lot of jostling to be ahead of someone else. And how you decide where people are ahead and behind is very complicated, right? So I think everybody agreed that people working in the ICU should be there. I mean, they're taking this risk. They agreed that people who are in urgent cares who are swabbing sick people's noses should be up in the front. EMS is coming to pick you up when you've got to think should be in the front. And that people in nursing homes, because they tend to be old and they tend to get really sick when they get this, should be at the first. But after that, it's really complicated. Does the 24-year-old caregiver or the 69-year-old person they're taking care of, who should go first? Well, I think the logic was, well, the most likely place that the 69-year-old is going to get this is from the 24-year-old caregiver who comes in, because that 24-year-old caregiver may go to parties and bars and whatever else and could bring it to the 69-year-old. The 69-year-old who is at home and homebound is not likely to go ahead and give it to the 24-year-old. And so that was the strategy for protecting the seniors. Now, you could argue that the 69-year-old is much more likely to get sick than the 24-year-old, but I think it was logical to suggest that if we can prevent it from coming in, that's going to be the biggest factor. So, for example, when we look at nursing home outbreaks, this almost never starts with the seniors. This almost always starts with the people who work there, who have lives of their own, get sick and bring it to the older people. So that was the strategy. And people will argue about that strategy, and it's going to be really hard to know now how we deal with that strategy, because it looks like it's kind of a free-for-all. Denise says, where do children fit in the vaccine distribution? There are no vaccines approved yet for kids less than 16, so they don't fit anywhere in the strategy. Now, both the Moderna and the Pfizer vaccine may expand their indications to a younger age. I've not seen any application for that. And one of the new vaccines that came up may also do for kids. So for right now, there's nothing for kids 12 to 15. So, Akio says, I need to go to Japan at the end of February or early March. It's required to have a 72-hour corona test negative certificate signed by a physician. From Oregon to my airport in Japan takes 38 plus hours. When I was in the Navy, I was stationed in Okinawa. It's a long flight. Can you allow rapid tests for international travelers due to this new rule? And so the story on travel tests is, I think it's a terrible idea. I think it's just an awful idea, because what we know is that tests, especially if you do them 3 days before, falsely call some of the people positive. So especially if you do a PCR test, that PCR test can be positive for 24 days. So let's say you're traveling on the 25th of February. You get the disease on the 1st of February, and by the 10th of February, we know you're no longer contagious. But the PCR test stays positive for 24 days. So if you did that test, you'd be positive, and you would be banned entry into Japan, although you would be the one person who would be not likely to spread it because you've already had it, been over it. So it falsely identifies some of the people who are past. But the bigger problem is that this disease is most contagious in the day or two before you have symptoms. And so again, if you get exposed on the 20th and get tested on the 21st, your test is going to be negative, but on the 23rd or 24th when you're traveling, you are going to be super contagious. So the tests miss some of the most contagious people, and they're an incredible hassle for people who travel. The other problem is that every municipality has its own rules. Some are 3 days, some are 5 days, some are 7 days. Some are PCR based, some are rapid based. Some require that be done at a special laboratory. So, for example, in Hawaii, they require that it be done in a trusted partner laboratory, and so you have to get it from them. So I don't know the Japanese requirements, so you need to very specifically check for the very specifics in Japan. Do they require an antigen test, or do they require or any test? Do you have to have the test results within 72 hours or the test within 72 hours? The problem is in these places that require a PCR and test results within 72 hours really hard, because our turnaround time on the PCR is sometimes 96 or 120 hours. So, here you have this big trip planned, and then you may not have the results back. If you are traveling from Portland, there is a special clinic set up at the Portland, in Portland. I don't remember, it's something urgent care that actually is a trusted partner for the airlines and for many of the destinations, and for way too much money, they will go ahead and do a test within the time frame and get you the certificate you need. So I would have you check with the Portland airport. They have a website that'll get you to those places that can go ahead and do this. Again, if they'll take a rapid test or if they'll take a PCR test, that would be fine. Unless you have some special deal like that urgent care, you are likely going to have to use a rapid test. And rapid tests are fine. Anybody can use rapid tests for anything. Public health does not restrict the use of that. However, I will tell you, I did this great study. Colleges, and they looked at people, and what they did was this test where when people had it, they did both a PCR and a rapid test. And what they found was that for the most part, for symptomatic people, both tests were great. If you were sick and had it, the PCR and the antigen test would both be positive. So for symptomatic people, you should use whatever test you have available. What it did show, though, is for asymptomatic people, they didn't always show up on the antigen test when they did on the PCR test. And that's a problem because they could still have been contagious. The other problem was that for people who were asymptomatic, you sometimes got a borderline positive on the asymptomatic people who really didn't have the disease. And then the problem, unfortunately, is that they'll get restricted or quarantined or whatever when they don't really have the disease. Now, it's only a few percent. It's only 2 or 3%. And so, if you're traveling to go to Japan or whatever, there's a 2 or 3% chance you'll have a false positive. That would be terrible. But would be really terrible if for example, 10,000 people going to a Ducks game, you say, our strategy is going to be we're going to do this rapid test on all of those people. What we would find is that we would miss some of the positives who are asymptomatic, and we would tell some of the people who were not positive that it looks like you're positive. And so the rapid tests are great for symptomatic people. For an individual person who needs it for a pre-travel test, it's probably okay. But in general, we should not be using the rapid test for screening wide populations. And I totally agree with that. So Nita says, my family has been eligible for the vaccine for weeks now, but nobody knows how or where to get them. Well, the problem is they're just not a lot. So as I said, public health has gotten 200 doses of vaccine, and those 200 doses of vaccine went to people who were in high-risk situations, such as doing urgent care, doing nasal swabs, and taking care of acutely ill COVID patients. As more vaccine gets here, we are going to expand so that we can cover more people. And, this is changing several times a day. So we do recognize that. We expect to have a lot better information over the next few days when the state and the feds give us information about how much vaccine we have on how to get it. If you are part of a group in 1A, so if you look at the Oregon sequencing plan, and these would be healthcare workers, these would be EMS and whatever else. If you're in group 1A and have not yet been able to find a vaccine, if you'll send an email to vaccines@douglaspublichealthnetwork.org, vaccines@douglaspublichealthnetwork.org, you will be able to sign up, and we'll try and match you with somebody who has a little extra vaccine. So, for example, there's one place in town that got some doses this week. They had a few extra doses after they give them to their high priority people, and we're trying to match them up. So, for example, the people who work at the jail, really high-risk people, need to get vaccine, and we're going to try and matchmake between them. We actually have somebody whose job it is to be that matchmaker, and we think we can do it. The problem is once you get to 1B and 1C, there's a ton of people, and to match those up is going to be much more difficult. But that just came out this morning, so if you give us a day or two or three to figure that out, that would be great. So Kathy says, I'm a retail pharmacist. When will I get the vaccine? So retail pharmacists are part of healthcare workers in group 1A, group 4. First of all, I would hope, Kathy, your pharmacy has vaccine, and if your pharmacy has vaccine, they could give it to you. So that would be great. So Amy says, what's the maximum number of cases for us to stay county level? I think you're meaning to stay in the high range. So it's 200 cases per 100,000 population over 2 weeks. Our county population is 112,000. So we could have up to 224 cases over 2 weeks for us to stay under that 200 number. Now, let me tell you about those numbers. So the numbers are complicated. Douglas County has numbers and the state has numbers. They always eventually match up. But we know about cases a lot earlier than the state does generally, because if there's a case at a clinic or the hospital or whatever, Dr. Gray or somebody at the clinic calls and says, hey, we got a case over here. So we can start the case investigation immediately. The state gets those later in the day when the labs go through in the middle of the night, and then they report it the next day. Occasionally, it's the other way around. Occasionally, somebody from Douglas County gets a test in Tennessee, and the test comes into the state lab, and they know about it before us. And that's why sometimes the state number is a little higher, or our number is a little higher. In the end, they always match. So if we had 224 cases in that period, we're good. We have 225 cases, we then get into the extreme range, and then we need to close things down again. Really, 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 I would hate to do that. So where would we get the vaccine in Canyonville? And again, for people in 1A, if you'll send this to vaccines@douglaspublichealthnetwork.org, we'll get you matched up. If you're in groups 1B or 1C, again, that just came out this morning, and we do not have a plan for going how to do that. So Sandy says, are folks with COVID being treated with the FDA-approved monoclonal antibody drugs? Not enough. So this is a real problem. So these monoclonal antibody drugs came out, and they were really arranged for nursing home patients. And they were arranged for nursing home patients because nursing home patients are already in nursing care, right? There's nurses around, that's why they call them nursing homes. They tend to be sick, and they tend to get sick very quickly. So the goal was that if somebody in a nursing home got this disease, they would be moved to the COVID unit, and then in the COVID unit, they would get this monoclonal antibody drug. And then if there was an outbreak, they'd find people really early, they'd get them in the unit, and they'd treat them with the monoclonal antibody drug, and it would decrease the severity for that really complicated group. Unfortunately, what happened is after the president got treated with this in the hospital, he pushed to make this available to everyone. And unfortunately what happened then is it made it available to no one. Because, for example, if I came down with the disease tomorrow, I would then have to go to a place while I'm totally contagious, wait around for a few hours. The drug would have to get delivered because they didn't know I was coming. Have to get delivered, have to get infused. You have to wait around for an hour and expose all of those people while I was getting the drug. And so it is a very complicated drug to give to the general population. Because of that, it hasn't happened. Now, we have some providers in town who want to do it. I don't think they've started yet, but we do have some providers who want to do it. It is overall, for the general population, although it's approved for anybody with mild or moderate disease, it doesn't make that much of a difference. So it decreases your risk of going to the emergency room by about, say about a half, a little bit more than that, but by a half. Well, if you were a 34-year-old, your chance of having to go to the hospital is only about 1 in 100, so it reduces the risk from 1 in 100 to 0.5 in 100. And so it really makes sense to give it to high-risk people, like in nursing homes, who have about a 6% chance of winding up in the emergency room, and to bring that down to about 2%. That would be that's a great deal. It's not such a great deal if you're 34 and your chance of going to the emergency room in the beginning is low. So this has been a totally muddled message about the monoclonal antibodies, and I think when the story about this gets written, it will be one of our greatest failures. So what underlying conditions qualify us for getting a vaccine for those of us under the age of 65? I don't know. The feds put this out today with no clarification that I could find. I'll look at it tonight. I've been running between things today. I'll look tonight to see if they put any clarification. Underlying conditions is a very broad range, right? So you'll occasionally find the 15-year-old say, do you have any problems? No, I'm just fine. That's great. But by the time we get to be 40 or 50, almost all of us have accumulated one or more underlying conditions. Maybe high blood pressure, maybe sleep apnea, maybe obesity, maybe rheumatoid arthritis, and which ones qualify and which ones don't, and does the severity of the illness count? So diabetes out of control would be a big risk factor, but what about high blood pressure perfectly well controlled? And so we really, really, really need some guidance from the feds on that, and there was none coming yet today. And that's why I asked for people to give us a few days to figure this out. So Charlene says, when is the vaccine going to be available for first responders? Already is. So first responders, our EMS people in town, great people, have agreed to go ahead and take the lead on first responders. So the first responders are getting the vaccine through our EMS providers, and they're already well underway. I heard today that they're going to give a zillion vaccines today. So this is great. So that's it. So Charlene, basically we're doing this since first responders all work for somebody, we're doing it by their employers. So if you work for X ambulance company, they should contact Quad Valley Ambulance or Douglas County Fire District 2 to get signed up to get this. So first responders is been about the easiest group, since first responders kind of all work for somebody else, and EMS can give vaccine themselves. This has been great. And actually, I think we've done a great job of getting our first responders vaccinated. So Karami says, does the 2-week case count affect school reopening? Yes, but the numbers are very high, so it will not affect our current school reopening at this. So the new guidelines for school reopening really relaxed it a lot. That allowed a lot more schools to come in. So Linda said, is Oregon going to stop holding back the second dose as the recommendation has changed? Ugh, Linda, I wish I had some clarity here. So in the past, what happened? Until 9 o'clock this morning, what happened was the feds held back doses for us. So if Hospital X got 975 doses of the Pfizer vaccine, the feds held back 975 doses for Hospital X, and 3 weeks later, they shipped this. They called these the prime dose and the booster dose, and they shipped it. This was 975 of the booster dose to go with the prime dose. What they're saying now is they're going to release all of it, so I don't know what's going to happen. and nobody at the state knows whether, when the feds release all these doses, how we're going to deal then with the booster dose. There was a little thing from the feds that said, oh, and we expect new manufacturer to be able to provide you with your booster doses. So again, none of this was written. So I was working all day today with press releases. And I will tell you, press releases are not a particularly good way to do policy, because the press releases don't really tell you those details. So again, this is one of the things we'll figure out over the next little bit. So, have you heard any personal experience of how people are feeling after their second dose, mild symptoms? So what we've seen is that people with the second dose tend to have the same kind of symptoms as the first dose. Some achiness, some fever, but a little bit more in severity than the first dose, but not a lot. So what we've seen in the county was that the people who got their first dose of vaccines, almost nobody missed work the next day. That's a pretty good sign, right? So that if you were sick enough, you might miss work. We've had very little work loss second day. Some, but not little. Today your hotline told me that 65 and older won't get the vaccine until April. Pamela says, well, so that was the answer as of this morning, and we belayed that later on. So it all depends on how much vaccine we get, right? So there's 15,000 people in Group 1A, maybe 20,000 or so people in Group 1B, depending on how you look at it, and then another 20 or 30,000 people in Group 1C, which are the people 65 and above. So, and previously, you had to get 2 doses for the people in the first group. So you had to get through 30,000 doses in the first group, 40,000 doses in the second group to get to that group in 1C. The stuff that came from the White House today totally puts us up in the air, and we don't know whether we're going to hold off on the second dose and get to people in 1C sooner. We don't know if we're going to get a lot more vaccine and could get them sooner. But in general, unless we're going to find new doses, it does look like people by the time we get to the end of 1C, that is people 65 and above, it's going to be May. I mean, unless they conjure up new doses, or we use split doses, or we don't go with the second dose, just the number of doses that are there won't get us there till May. Think about 50% of the people are fit in this group of hospital workers, first responders, people in nursing homes, people 65 and above, and those with underlying conditions. That's about 50% of the population. So to get 50% of the population of the U.S. 2 shots, so 50% of the population in the U.S. is 165 million people. To get them 2 doses, you would need 330 million doses. We're not going to get 330 million doses delivered to the U.S. until the end of the year. So there's a lot of this screwy math that goes on, and it's not that we're trying to deny doses to people. It's that there just isn't that many doses made, and so it's maddening to me, because I would love to magically vaccinate everybody tomorrow. And the part that I control is the local distribution and the number of vaccine providers. We've got that taken care of. What we don't have is enough vaccine. And it's not that I'm denying it to a 62-year-old with underlying conditions or a 90-year-old person like my mom. It is that you can't conjure vaccine from thin air. Misty says, what's required for proof of residency to get the vaccine when it's my turn? So it depends. If you get the vaccine because you work somewhere, it's the place you work. So, for example, at OHSU, there are a lot of people who work at OHSU who don't live in Multnomah County. They live in Clackamas or whatever counties. And again, OHSU vaccinated them because they work there, not because they live there. When we do things that are based on the county level, we have generally not looked for residency, but I don't think we're looking for people to cross county lines to get it. We really don't want to have these big camp out in your car overnight drive-throughs. There's so many issues with that. And so what we are going to try and do is get people signed up. We might, when we do these and open to bigger population, we might ask to look at your license to be sure that you're Douglas County residents, but we don't know. So Lisa says, I've heard that if you get the vaccine, you can't give blood. Is that true? Actually, I don't know. I give blood all the time, and I don't know. So I'll have to look that up. It wouldn't be forever. After you get a vaccine, they want you to hold off for a while, but I'll see. So Linda says, since CDC says now people over 65 can get a vaccine, when do you plan the vaccine? As soon as we get this. So as soon as we get the vaccine, and again, the Douglas County plan is to have lots of different providers where you can get it. Your doctor's office, the clinics, maybe EMS, maybe dentist's office, maybe ambulatory surgery centers, lots of different places to get it, so that where you don't have to wait in this long snaking line and then wind up not getting it. So Kat says, does the vaccine prevent you from transmitting it to others? Don't know. We don't know. I mean, that was not part of the study design for either the Pfizer or the Moderna vaccine. So it is possible that people who got the vaccine got an asymptomatic case and spread it to others. Don't think so, but we don't know. So when can home caregivers get the vaccine, Michelle asks. Well, home caregivers are in group 1A, group 3, 2 or 3, depending what they work. And so they should be getting the vaccine right off. But again, it depends upon if the new federal thing says it's a total free-for-all and just whoever shows up first gets it, or whether we're still going to prioritize home care workers higher than others. And the answer is I don't know. So if a person tests positive, if a worker tests positive, Jim, are we obligated to inform gym members that worked out with the employee? Well, employers are generally required to inform others if they have a close contact. And so, for example, if you were a worker at a gym and you had less than 6 feet, more than 15 minutes, especially if you were unmasked with somebody else, then we would expect that the gym would tell that those workers. On the other hand, if you had one worker sitting over here, wearing a mask, more than 6 feet away, otherwise following the rules, there would be no reason to have to do that. We've had a lot of workplaces where there have been positive workers. And again, we look carefully to see if those workers have had close contacts with customers or others. And when they do, you have to tell the customers. But when they don't, there's no special reason to do that. There's enough disease around. That that we don't think so. So when will spouses of healthcare workers be able to get the vaccine? Angie asks. We think it depends not on your relationship. It depends upon your individual exposure. So my wife would qualify rather than by anything that I do. There was some talk early on that spouses of eligible people would otherwise be covered, but that's nowhere in either the Oregon or the CDC guidance. Beverly says, will DC set up a sign-up list for the January 23rd rules, and have all hospitals comply with setting that up? I mean, I have no clue. I mean, this stuff just came out today, so I really, really don't know. I mean, we are planning to do a mass event. We are planning to do mass events in the future now that we know we're going to get enough vaccine, right? And the people said, well, why didn't you do a mass drive-through? The answer is, well, we would plan to do 400 an hour or 300 an hour. We only had 200 vaccines total, and those had to go to EMS and urgent care workers and whatever else. So we would have had about 30 for a drive-through. Really doesn't make sense to set up a drive-through for 30. However, I think by the end of next week, we will be able to get batches of 975 or more, and then we will be able to do that. We would prefer, when we have these mass events, to have people sign up and get a time. If you don't, you say just show up. If you run out of vaccine, then you've waited in line, 10 hours and didn't get a vaccine. Second, behavior in lines can sometimes be problematic. And we also think that some of the most vulnerable people, older people, sicker people, will really have trouble sitting in their car overnight. So what we always prefer to do in these things is to have a time and have you come in time so you don't wait. So anybody who's had their nose swabbed by me or my friends at the fairgrounds know that on our COVID testing, you call, get an appointment, say to show up at 10:15 or whenever, and most people, if they arrive at 10:15, they're done by 10:30. So there's not a long waiting. Once you have an appointment, you have that appointment. We know then how many appointments we made, so we know how many kits and tests to have, so we never run out of tests, and you never get to the line and say, sorry, we're full. And that's how we'd also like to do it with the vaccine. We have not exactly figured out the sign-up process, but when we do, we'll let people know. So Janice says how we know when it's our turn to get the vaccine and how we know where to get it. So again, that's all coming through. That all changed today with this White House arrangement. So for example, until today, when we thought we were in the 1A group, we have a way for people in the 1A group to sign up and get the vaccine given. So, and we're still going to do that now until these federal rules get finalized, right? Because this was done in a press release and not in any rules that we know how to follow. So until those rules come out, which we think is not going to happen until January 23rd, we're going to go ahead and do it according to the previous, which was to try and get everybody in 1A done. And so if you are in a group in 1A, you should send an email to vaccines@douglaspublichealthnetwork.org, and we will try and get everybody in 1A vaccinated just as soon as possible. Yeah, so Casey said, is there's lessons learned from testing, vaccination? Yeah, yes there are. So here are a couple of lessons. So if you look around the world, there are some places that have done very well with this pandemic and other places that have not done as well. I think the places that have done the best, a couple things. One is they've taken liberties with personal freedoms. So Israel and Korea and Taiwan that have done great jobs, I think, with contact tracing, they have, without anybody's permission, installed tracking software on your phone. And so if you're in Israel, they have tracking software on your phone, and they could tell if you were within 6 feet for 15 minutes with somebody else who had COVID, and then they would be able to say, hey, look, on Tuesday, between 2 and 3 o'clock, you were within 6 feet for more than 15 minutes from another patient, from somebody who had COVID, you need to go home and quarantine. That has really helped their contact tracing. In Korea, that has really helped their contact tracing. I do not think that would be acceptable in the United States. So one of this is as a society, if we choose, we could have fewer personal liberties and better contact tracing. The way we do it, where we ask for, hey, looks like you were probably contagious on Tuesday and Wednesday, who were you around? And people may or may not tell us that they were around anybody. We don't look at closed circuit TV coverage. We don't look at any of those things. Now, Korea does. So South Korea, there's a very interesting story about this one woman who exposed a bunch of people, and they have her minute-by-minute timelines. Like, how in the world did you know that? Well, they tracked her phone, and then they tracked all the closed circuit TV cameras where she was, and they could tell where she went, and she went to a cafe, and then she went to church, and then when she was here in the next place, and so they could track all of that. So we in the U.S. have chosen not to do that. And because of that, our contact tracing is not nearly as good as those areas. So one of the lessons is you trade stronger public health measures for stronger liberty. We clearly in our country have chosen stronger liberty. The second thing is planning. So Israel planned very well, and they bought a lot of doses of vaccine. They bought more doses of vaccine they would need, and because of that, they knew about it. And the third was there was incredibly clear messaging about how and when they were going to give vaccine. In our country, it has been a total mess. I mean, I really look at a lot of this stuff. I go to a lot of meetings, talk to a lot of people, and I think I know the answer, and then 4 hours later, it's different. And so many people are chiming in. So there's the CDC, and then the FDA, and then HHS, and then the Army, who's running the logistics, all are saying different things. And because of that mixed message, and because we didn't order a lot of vaccine, we are not going to do as great as those other players. And So we've chosen to do it that way. We chose, for example, for every state in the U.S. to have its own vaccine plan rather than having a vaccine plan for the country. Israel had a vaccine plan for the country. We have chosen in our country to have 50 different school plans. Other places have chosen to have a single school plan. So by doing these 50 times over, we get a lot of different stuff. So Florida has chosen a very different program from New York, which has chosen a very different program from Oregon. And there's probably no one of them which is better than the others, but there's 50 different ones of them, which is very, very, very complicated. So Ginger says, how long after the second vaccine are you considered immune? So let me give you sort of the general thing. So after the first vaccine, probably 2 or 3 weeks later, you got about 80% protection. After the second vaccine, 7 days after the second vaccine, you're at the 90 to 95%. And that's where some of this talk about, well, should we just do a single vaccine comes from, because at least younger people get pretty good protection just from the one vaccine. I would again point you to a very nice letter. It's a guy named Morris Sharp who writes it, and he wrote one yesterday, red shot, blue shot, one shot, two shot, and it's a fascinating thing which would show you the different strategies that we might use about how to do shots. So Tanya says, this is a good idea to take Benadryl before the vaccine. Certainly no problem with taking Benadryl before the vaccine. I hate the way Benadryl makes me feel. It makes me feel like I'm sleepy. So I wouldn't, but if you want to take it, that's perfectly fine. So Karina says, I've had a severe reaction to shrimp, Bactrim, and IV contrast. So I have to take prednisone and Benadryl prior to IV contrast. You would be higher risk. So we certainly know that people who've had severe reactions to sulfa are more likely to have severe reactions. So yeah, you'd be at moderate risk, and I would certainly talk with your doctor about that. You might want to wait and have other people around you get vaccinated. That's a reasonable way to do it. You might want to go ahead and take pre-medication with the prednisone or the Benadryl, but that's something your doctor would work on. Or you might want to wait until a different vaccine comes out. We think that the AstraZeneca and Johnson & Johnson vaccine, if and when they finally get approved, will not have these immediate reactions. So these vaccines, the Moderna and the Pfizer vaccines, are really within minutes active. And so what they are is, again, little bits of messenger RNA covered with little fat balls. And what happens is they get injected, those little fat balls get picked up by cells who think this looks like a little fatty treat, and they gobble it up. I mean, I think of like the Dippin' Dots ice cream that you've seen. They gobble it up thinking that this is going to be a fatty meal, and instead inside is messenger RNA, which then tells your body to go ahead and make this. This all happens within hours or days, and that's why people have a lot of pain and soreness over the next few days. And we think the allergic reaction is also related to that hyperimmune response. But the other vaccines, the Johnson & Johnson and the AstraZeneca vaccines, are live viruses, and they work differently. They give you the vaccine, and then your body gets a very mild case of this new virus that got injected, and you have reactions later rather than right off. So, this is like other vaccines we give. Tetanus, a toxoid vaccine, really hurts. So if you remember ever getting a tetanus shot, it doesn't feel good. HPV, similarly, that kind of thing, really stings when you get it. Whereas MMR and chickenpox, which are live vaccine, you barely even feel when you get it, but you may get some side effects 8 or 10 or 14 days later. So yeah, you're high risk. I think people have had severe reactions to Bactrim. Those are people specifically noted as people who might have trouble with this. So talk to your doctor. Again, always talk to your doctor. They know you. They know better what's going on. So I would please have you do that. But that certainly would put you at moderate risk. Okay, a couple of interesting things that came out this week. One was the study on the asymptomatic use of the rapid testing on asymptomatic people. Not great. So again, we're not big fans of that. Now, if you need it for a specific reason, we're not going to object. But in terms of doing large populations, probably doesn't make sense. The other thing is the PCR test, that test that we started with, is a great test. It's quite accurate, but it's hard to do if you're going to do the deep nasopharyngeal swab. I mean, I've had that deep nasopharyngeal swab done maybe a dozen times. So when we teach people to do it, it doesn't make sense for them to do the first time on a patient because the patient won't know if they're pushing too hard or pushing. So I have them do it on me. So I probably had this done a dozen times, and you guys out there know who you are. I've had this done a dozen times, so it is distinctly uncomfortable. The second thing is it takes a long time to get back. We're taking 4 or 5 days to get it back. And so in 4 or 5 days for acutely symptomatic people, that's way too long to wait, especially when you now have a rapid test. So in the beginning, when that was the only test that was available, and that was the only way to get tested, that was the way to do it. So we did testing, and we've done 100 drive-through clinics at the fairgrounds. 100, maybe 101 now, drive-through clinics at the fairgrounds where we've done this. But the good news is there's lots of rapid testing available in the community that you get the results in 15 minutes. So somebody needed a test this weekend, so I got the test. And in 15 minutes, we could get the result of this test. And again, this test for symptomatic people is very accurate. So we're trying to push people away from the PCR and towards the rapid test because they are pretty accurate and much quicker. There are other places to get the PCR test now. Rite Aid is still doing the test, so talk to them about it. So we're moving down from twice-a-week testing to once-a-week testing because we want to focus more energy on vaccines and because we would really like people, if they are symptomatic, not to wait for our test, but to go ahead and get one of the rapid tests. One of the other things that came out this week is about long haulers. Unfortunately, a good percentage of people who are sick have symptoms for a very long period, although we're now out long enough, right? We have a bunch of people got the disease in February and March and April, so they're now 6 or 8 months. And what we're seeing is that some of those people, although long haulers, some of those people are steadily getting better, which is a good thing. That many of those people who lost their sense of smell or taste are getting better, and that a lot of the people who had fatigue are getting somewhat better. Now, not 100% better, and not 100% of the people, but the concern was that after 6 months, they may start to get worse again. We've really not seen that, so that's good. The other question that came up is about repeat infections, and it appears that having the disease first time gives you about 90% protection against getting reinfected. Not 100%, but about 90% protection, similar to what you get from the vaccine, so that's a good thing. How long will it last? Don't really know, although early people with antibodies in February and March, most of them still have at least some level of detectable antibody, and if they got challenged with the virus, might have a big rise in their antibody levels, as is typical, and be protected. So that's good news. The other not so good news is we're beginning to recognize there are some weird presentations of this. I mean, we talked about the fever and cough being the typical one, but now we're seeing people whose only symptom is diarrhea. And so that's been a problem because people come in with what looks everything like food poisoning, nausea, vomiting, diarrhea, and you think, well, you must have just eaten a bad sandwich or something. And it turns out that they have COVID. And so if you don't think of COVID and test them for COVID, you now expose all of these other people around. So there are a number of episodes at hospitals where people came in with what they thought was just food poisoning, put them on the regular ward, did not use a lot of precautions, and then a lot of other people got ill. The other one we're seeing is psychosis. So weird thoughts, not really sure where you're at or you're thinking not clearly, also associated with COVID. That's a bit of a concern. And so now the recommendation is really anybody who comes in with anything that should be COVID, since we have a lot of these tests, should get screened. So if you come in with fever and cough clearly, sore throat clearly, diarrhea, yes, you should get screened. Vomiting, diarrhea, yes, get screened. Psychosis, yes. And then the new one that's come up is what we call failure to thrive. So people who just decide they don't want to eat. So I heard about a case today that this person came in with vomiting, diarrhea. They weren't thinking clearly. They said, I just want to die. And it was really, they weren't quite sure what was going on. They tested them. They had COVID. When the COVID got better, their psychosis cleared. They were thinking clearly. They said, I don't want to die. I want to live. And they started eating and drinking. And so And so this is the weirdest disease. Every month we're finding new and different kinds of presentations of the disease. So Vanessa, do you have any more? If you don't have any more questions, it's 7 o'clock now, it's almost 7 o'clock, so we'll give it a wrap. Again, lots going on out there. Please be kind, especially when things change so rapidly. So here we have described these vaccine planning events like a wedding. And typically when you plan a wedding, you plan it apart a little bit, and kind of early on who's getting married. You usually know the date, you usually kind of know the location, you kind of know the guest list, and then you work away at the details as you get there. And that's how the way we've described this is that we knew vaccine was coming. We didn't know exactly when, but we kind of knew what we were going to have to do. This was during the wedding. They say, wait a minute, we have totally changed the rules for the reception. And now we have to sort of figure out all of those things. Who's going to give the vaccine? Where are we going to give the vaccine? Who's going to get it first? Who's going to be first in line? And who's going to be later? So just today we were dealt a big logistic challenge to get it done. Now, the good news is we don't have to be perfect. We just have to be really good about it. And I think we have every opportunity to be really good about it. We have so many great partners in the community, so many clinics and doctors and dentists and surgery centers and all those people working together. We've really not had anybody not rowing in the same direction. We've really had great opportunity. Secondly, we have tremendous support from the county and especially the county commissioners. I mean, I've been doing things a long time, and Tim Freeman and I probably talk or write sometimes several times every day, and always is, what more can we do for you? What else do you need? What can we do for you? And so the support we've gotten from the county commission has been incredible. When I talk to the other public health administrators in other counties, and I say, well, geez, if I need anything, just call the county in, and they make it available. They say, well, that just doesn't happen in our county. And it really does happen in our county. So, for example, in planning this big event, we said we need the fairgrounds. Got it. We're going to need help in traffic control. Got it. We're going to need these things. Got it. And then never it's, well, maybe, I'm not sure. It's always got it. So we really have that. And I think it shows. I mean, we are really the only big county in Oregon that's in the high range and is allowed to open bars and restaurants. We're the only county that has really most of the schools back. Some of the other counties are struggling to get schools back. We've had schools back. We've had the gyms open. We've had churches open. So we've really been able to do these things, at least in part because everybody's worked together and we've had such great support from the people who really could help us. Now, are we perfect? Absolutely not. But we're pretty dang good at doing these numbers. You can't look at these numbers and have the second lowest rate of large counties anywhere in the country and not think, we're probably doing okay. And so what we're asking is give us a little bit of time so how we can figure out how to get vaccine to groups 1B and 1C, which we didn't think we were going to get to until later, and now we're told we're going to get sooner. So we will be working really hard over the next, continuously to go ahead and get plans so that we can get as many people vaccinated as soon as possible. Because again, I think the vaccines are a way out of this. We've said that if we can get a good percentage of the population vaccinated by Memorial Day, a higher percentage by 4th of July, and then almost everybody by Labor Day, next school year will look so different from this school year. By then, if everything works as we hope and there's no mutations of the virus or whatever, that by next fall we'll have a low rate of disease. Schools will open just like they always did. We'll have a football season in the fall. That kids will go trick-or-treating in October. And then things will be somewhat back to normal. Now, will they be perfect? No. There'll still likely be some of this disease around because until we eradicate the disease worldwide, there will still be some disease around and there will still be nasty pockets of disease in the U.S. Remember, there are a lot of asymptomatic people who spread, so you're not going to be able to totally drive it to zero. But, if the county report came out today, said we had 2 cases, now this is our 14th case this week, that is totally manageable. But when we have like some of the cases, hundreds of cases in Lane County or Marion County, hundreds of cases a day, there's no way we can say that's normal. If you look what's happening in California or Arizona, where the hospitals are just filled, there's no way you can consider that normal. A friend of mine said today that their sister just got a job at a hospital in California, and there are really sick people everywhere. The hallways, every nook and cranny, there are sick patients, and there's not enough nurses and not enough equipment. And these people, because there's so much disease in the community, family is not visiting them. So here there are these desperately ill people who are in a hallway getting care as best people can deliver it, but still not very well. And they're not seeing their families in their dying days. I mean, when we all think about how we would like to plan our deaths, it would be at home, at peace, surrounded by family. And sadly, most of these people who are dying in those hospitals, those overcrowded hospitals, are not in peace. They're not with family, and they're not in comfort. So really, really, really want to avoid that. And I think we're going to get there. So please be kind. Please give us a little bit of time to figure out how we're going to go ahead and make these enormous changes and how we're going to distribute the vaccine. And we'll see you again on Friday. Again, this is Dr. Bob Dannenhoffer, Public Health Officer in Douglas County. Be safe and be kind.